concerned, I think primary angle closure is a very, very important topic for us to know. And as our first speaker was not able to join today, I think we'll start by just trying to tell you why this is important. If you look at people over the age of 40, you will find that at least 1 in 5 have some form of primary angle closure disease, and about 1 to 2% of them actually end up with very significant visual morbidity. So keeping all this in mind, and the fact that, in hospitals, primary angle closure glaucoma is almost equally prevalent as primary open angle glaucoma, I hope that this session will help us all in sort of identifying patients and treating them appropriately. So, Dr. Okay, so I think, Devang, we may need to start with you, the role of anterior segment imaging. But would you like to say a few words about the prevalence of primary angle closure in India?
I think I think we used to think that open angle glaucoma is the more prevalent one, but particularly in our country and in the Asian continent, angle closure disease is as common as open angle. So it is a must whenever we start managing these patients. Gonioscopy is a must to rule out what type of a glaucoma we are dealing with. Otherwise, we find that this is one big lacuna in management by general ophthalmologists. Gonioscopy is missed, and we keep on treating, and we also have to know that the behavior, the progress of angle closure is quite different. Open angle glaucoma is a silent, slowly progressive disease, whereas angle closure, if you miss, I think we are in for a problem.
Dr. Shantam, would you like to talk about the magnitude in India?
Yeah, actually, if you take the prevalence of angle closure glaucoma in the population, we've had a number of population-based studies done, and it's almost 3 to 5%. If you take primary angle closure suspects, it comes up to almost 7 to 10%. So if you take primary angle closure disease, in 2010, we reported that it was almost 26 million affected. So that's a really large number, and primary angle closure suspects are going to progress over a period of time. So as was suggested earlier, gonioscopy is the most important thing. I think it's still not prevalent. A large number of general practitioners are a little hesitant to perform gonioscopy. After the age of 30, if a person presents to you, it has to be part of your comprehensive examination.
And I think the last thing we'd like to emphasize is that this is actually preventable. So if you catch a patient who is having a high risk while he's still a primary angle closure suspect, you can prevent the progression. Similarly, if you have a patient who is beginning to show us some changes on gonioscopy like blotchy pigment or pus, we can actually prevent him from progressing to developing a glaucomatous optic neuropathy and other problems. So I hope we have emphasized how important it is for Indians to be looking at and looking for angle closure glaucoma. And we'll move on to our speakers. Dr. Sirisha is going to be a little bit late, so Dr. Devang will start with imaging.
Thank you, ma'am. I would be speaking on anterior segment imaging, and this is pertaining to angle closure glaucoma. So if you look into imaging, we have gonioscopy, as been reiterated by all the stalwarts, that it remains the current reference standard. However, it is a subjective assessment, and all the diagnosis that we do is based on the gonioscopic findings. And it is a subjective, the disadvantage being that it is a subjective assessment. It has contact procedure. There may be inter-observer variability, and different lenses that we use can alter the angle appearance and the interpretation. Therefore, we needed an objective assessment to visualize the angle structures. So that is when the use of anterior segment OCT has come into vogue, and not only in visualizing the anterior segment, but also angle analysis, lens analysis, and bleb analysis. So in the quantitative assessment, if we look, the prerequisite for quantitative assessment is the identification of the scleral spur, which is seen as a bump in the inner wall of the sclera, and this is the thing that the observer or the person has to mark. Once this is marked, For all other angle assessments, the machine itself has inbuilt tools into it, which measures the angle, opening distance, various other angle parameters like TISA, AOD 500, etc. And the newer thing that has come into vogue is the iridotrabecular contact index, that is known as the ITC index. It is a quantitative measure of the extent of angle closure across 360 degrees of the angles, and it is expressed in percentage. If you look into this, we can see that the angle is totally closed, and if you look at the graph, here we can see that 94% of the angle is closed, and 45 degrees of out of 360 degrees, 45 degrees was not visible because of the lids. So in the quantitative assessment, here we can see that before doing a cataract surgery and after doing a cataract surgery, how the amount of angle has opened up. And if you look at the ITC index, above it was nearly 100% closed, and here we can see that 74% has now it is 74% open. So if we can also do a qualitative assessment, if you look at various serial photographs closely, we can see at the top how the angles are closed. Here it is narrow, and the lowermost figure we can see the angles are totally open. We can also visualize plateau iris configuration. For these we have to clearly look at the scans, and we can see that there is a steep rise of the iris against the scleral wall, and then there is a acute angle change in the iris pattern, and this is how we can also see the plateau iris configuration on the anterior segment OCT. And secondary angle closure glaucomas, especially when these young patients with acute rise in IOP, and you look at the anterior chamber, it is on the shallower side, you do a gonioscopy, it shows occludable angle, you are always suspecting something which is secondary. So when you do anterior segment OCT, we can also see that there is a fluid which is there, suggestive of ciliary body effusion. There's also a very high definition angle visualization, where we can see the structures of the trabecular meshwork, the Schwemm's canal. This is a very high definition view doing a laser peripheral iridotomy, and post we can clearly see how the angles have opened up after doing a peripheral iridotomy. Then we also have a 360-degree gonioscopic view. So in this is especially useful when you are doing some angle-based surgeries for the patient, where you exactly want to know which position is the peripheral anterior synechiae, and there you want to target that part particularly in the OT. Especially in this, we can see that in the supratemporal area, we want to do our goniosynechiasis in this patient. Then we come on to the lens analysis. So in the lens analysis, as the previous IC also reiterated the importance of the thickened and the anteriorly placed lens, which leads to the angle closure. And here we can see how the lens vault has increased and the lens thickness is totally overall increased. We can, in patients who are operated, it is very useful to look at the bleb wall, bleb thickness. In cases which patients who have very thin cystic avascular blebs, where we want to do some bleb remodeling procedures, we can do these scans. We can also see there is underlying scleral defect. You can see that there is no intensity here, and one can be well prepared for the OT and without any surprises. And we can look at the ostium, whether the ostium is blocked, how the bleb is functioning. Then next, one should also know about ultrasound biomicroscope, that is the UBM. So the clinical utility, again similar, it is similar to that of the ASOCT. Again, qualitative and quantitative scans can be done. But one should remember that anterior segment OCT cannot visualize anything behind the pigment epithelium. So that is why we need the UBM for those cases, especially in cases where we want to diagnose malignant glaucoma, which this is basically a very important and diagnosis which needs to be made early, because earlier the diagnosis, earlier the intervention, and the risk of irreversible vision loss is avoided. Then various lens-induced glaucomas, we need to know what is the cause. Like this, in this there's a subluxated lens, in this there was microspherophakia, then we have a very thickened phacomorphic type of a secondary glaucoma, and anything which is like iris cysts and ciliary body tumor, we need UBM to help aid in the diagnosis. So if you look at the advantages of the anterior segment OCT, it is non-contact, it is fast, and a 90-degree technician-patient interface. The only limitation being that anything behind the pigment epithelium cannot be visualized, and that is when we want to use UBM to aid in the diagnosis in such complex cases. So to summarize, imaging the anterior chamber angle is germane in understanding the angle anatomy and pathophysiology of angle closure glaucomas. Gonioscopy still remains the gold standard, and AIOC2024 being a non-contact procedure enhances visualization of angle structures, provides a 360-degree evaluation of the angles, and 3D imaging of the anterior segment. And UBM being a contact procedure, it is useful in particular cases, and multimodal imaging is useful in decision making in various complex secondary or combined mechanism glaucomas. Thank you.
Thank you, Dr. Angmo. She's really covered all the important aspects of imaging. You may think that imaging is not really required, and good clinical evaluation gives you most of the input. But these imaging modalities have helped us understand the complex mechanism of angle closure glaucoma in research, and there are clinical applications which she has described well. So thank you. We also have a Gono pen which has been developed by Dr. Mani Bhaskaran when he was at the Singapore National Eye Center, and that becomes commercially available. I think it will be a really useful tool to use. Thank you.
Thank you.
So the next speaker is Dr. Tutul Chakravarti. She will be talking about an important treatment modality for angle closure, laser peripheral iridectomy or iridotomy, and argon laser peripheral iridoplasty.
While Tutul comes up, are there any questions that anybody would like to ask about imaging? As Dr. Shanta pointed out, most of the information we want to get for clinical management, we're able to get on a good gonioscopy. So the question is, how does one get as much as we can? So we'll come back to that with Dr. Sirisha, but Dr. Tutul is ready.
Good morning. When and how to do a laser PI and LPI. Now first we would like to discuss about the classification of primary angle closure, types of PAC, PACS, PAC, PACG, and APAC. Now LPI is the cornerstone of angle closure management in primary, acute, subacute, or chronic angle closure. LPI increases angle width in all stages of PAC. LPI breaks relative pupil block. Next question is indications of LPI. Now, the efficacy of LPI is dependent both on the underlying mechanism causing angle closure and the stage of the disease. Like in PACS, only 0 to 8% need further treatment, while many PAC and ACC, they need further treatment, like 42 to 67% in PAC and ACC 21 to 47%. However, most of the PACG, like 83 to 100%, they need further treatment. Now, other indications of LPI, play to iris configuration, combined mechanism glaucoma, contralateral eye in APAC, secondary angle closure with pupillary blob, aqueous misdirection. LPI eliminates a reverse pupillary block in pigment dispersion syndrome. It does a prophylactic LPI where iridocorneal angle change due to some systemic drugs like topiramate. Now, in the an informed consent is needed. You should inform the benefits of LPI. For PACS, it prevents PAC or PACG. Now, you also inform the risk of LPI, like IOP spike, dysphotopsia, AC bleeding, cataract progression, risk of closure, corneal damage, and the chances of repeat procedure. Now, pilocarpine 2% is needed to make the iris stretch, reduce the iris thickness. Now, please be careful when you are using this for high myopic. Now, brimodidine or apraclonidine minimize post-LPI IOP spike and bleeding. You can use acetazolamide 250 mg or 500 mg topical proparacaine. What are the lenses for LPI? You can use either Abraham lens or Weiss lens. Now, which laser to use? That is Argon or AIOC. Please remember Argon laser LPI is associated with high rate of failure, that is 20%, and closure 30% in brown eyes. Less total energy is required in the ND-AIOC than with the Argon laser. These are the laser parameters. Please remember, use the minimum amount of energy to create the iridotomy. Lens capsule damage is possible more than 2 millijoule energy. Now, what are the sites of LPI? Some recommend superior quadrant between 11 to 1 o'clock. Let's please remember this is 10 to 7% superior dysphotopsia in superior LPI than 2.4% in temporal. In the presence of silicon oil or gases, perform inferior LPI. In AC bleeding, superior is more than inferior, no difference between superior versus temporal location. If the first few laser pulses are ineffective in the area selected, consider moving to a new site. In temporal 1, peripheral 1/3 of the iris, just anterior to arcus and within the iris crypt. PI is easier at thin areas at the base of the iris crypts, slightly superiotemporal to avoid long posterior ciliary nerve and avoid prominent iris vessel. What is the endpoint of the treatment? Iris is treated until gush of fluid seen flows from the posterior into the anterior chamber. Size, ideal iridotomy size at least 150 to 200 μ. Transillumination through the iridotomy is not a reliable indicator of patency. Manage bleeding. Now, apply pressure to globe using laser lens. You can use argon or diode laser to coagulate area of bleeding. Now, here we can find is a small LPI opening with the white collagen strands at the stroma, and you can see a thin membrane at the base of the PI. Now, so repeat LPI is needed, and here we find the PI is completely penetrated, and this is a widening of the anterior chamber angle. IOP increases more than 10 mm of mercury in 30 to 35% of the eyes. So check IOP 30 to 60 minutes after LPI. Prednisolone acetate 1% 1 drop 4 times daily for 1 week. Follow up in the 1 to 2 weeks to check for AC reaction, PI patency and gonioscopy to assess improved angle configuration. Regarding bilateral same day LPI, when the patient access to eye care is limited, you can do it. Smaller iridotomies are known to be at increased risk for closure, that is 60%. Closure may occur within the first 24 hours. Most closure occurs within the first month. Any doubt about the patency of PI, the opening should be enlarged or a second PI should be created. Now, ZAP trial found a 2/3 decrease in PAC occurrence after LPI. The question is, in that case, should we do or treat all occludable angles with LPI? Now, in that case, we have to follow the natural history of PACS. How much PACS is converted to PAC? Now, again, ZAP trial found conversion from PACS to PAC is relatively low, and most PAC cases were asymptomatic. Again, the cataract progression rate was significantly greater in 6 years following LPI for PACS. Considering all this, widespread prophylactic LPI for PACS is not recommended. Now, prophylactic LPI prescribed primarily for the high-risk population, like those who are having baseline higher IOP, fellow eye in APAC, and also shallower limbal anterior chamber death. Next, come to ALPI. ALPI can be used in treating chronic angle closure when angle closure persists after LPI. In 20 to 30% of eyes, a patent PI may fail to relieve angle closure and treat the underlying disease mechanisms such as plateau iris configuration. ALPI eliminates appositional angle closure resulting from mechanism other than pupillary block and angle closure originating at an anatomical level posterior to the iris. What are the indications of LPI? LPI can mechanically open up the angle in APAC in the early stage of non-pupillary block, AAC, plateau iris syndrome, nanophthalmic eye, iris and ciliary body cyst, safe and effective as a first-line treatment of acute phacomorphic glaucoma. These are the ALPI procedures. In ALPI procedure, aim at producing a contraction burn at the post-peripheral portion of the iris. These are the scars from LPI in eyes with plateau iris syndrome. Now, a recent study, they investigated the efficacy of ALPI versus PGA in PAC. 80 PAC or PACG subjects were enrolled who underwent LPI and had at least 180-degree persistent appositional angle closure and IOP more than 20 mm of mercury after LPI. Now, after 1 year, ALPI was associated with a huge failure rate, that is 30% and lower IOP reduction compared to PGA therapy. Conflicting results regarding efficacy of LPI, that is regarding change in extent of peripheral anteseneca, reduction of IOP and anterior chamber morphology between ALPI and LPI alone. So we could conclude that in LPI
Dr.
increases
Tutul, can you
angle
summarize,
width.
please?
Yeah, just the last slide. LPI increases angle width in all stages of PAC and reduces IOP in eyes without extensive angle or disc damage. Additional treatment is needed after LPI in PAC, APAC and PACG eyes, angle closure persists after LPI in non-pupillary block of angle closure. Treating all PACS with LPI with hope of preventing progression to PACT is not recommended. Regarding LPI, all these studies prove that the evidence is very uncertain about the effect of LPI. But please remember that ALPI is an opinion to consider in the acute stage of the disease. Thank you.
Yeah, very nicely covered, Dr. Tutul. Like you very rightly pointed out that only 22% of PACS progress to PAC. So prophylactic PI in all cases of PACS is not needed. What are the cases of PAC in which you would recommend doing PI?
Those who are having higher baseline higher IOP, and also those who are, I mean, for PAC, if the baseline IOP is higher, I can do the AIOC PI. In that case, I do not discriminate. But for PAC CS, I can discriminate.
Yeah.
I mean, when to do the AIOC PI. Madam is not happy.
I think Tutul mentioned something about cataracts increasing 6 years after a surgery at Chennai.
This is
Laser iridotomy.
Laser iridotomies. But I think both the Singapore study and the 14-year ZAP study showed that there was no increase in cataracts.
Yeah,
so I think
maybe-
it depends on
maybe
what
the
you use.
ethnicity of the population.
Possible, and also what
they
was
were not
used.
visually threatening. They were a lot of them were cortical cataracts.
So, thank you, ma'am.
Thank you.
So, now I'll invite the next speaker. I think Dr. Siresha is here. Achha, Amit. Dr. Amit Porwal, and he's going to talk on combined cataract surgery with trabeculectomy.
Thank you, Chair and AIS, for inviting me and being part of this national symposium. So I'm going to talk on combined cataract surgery with trabeculectomy, no financial disclosures. So what are the major indications for this? Patient should have a cataract within glaucoma patients where there is failure to achieve target pressures by medications. There are issues related to compliance, adherence, and drug-induced side effects. There's borderline control IOP, disease progression, or advanced glaucoma optic atrophy despite magical medical therapy. When you have uncontrolled glaucoma, but there is an urgent need to restore vision, or when two operations are not feasible. So basically, these are the indications for the triple procedure. Advantage is being it eliminates the need for two separate surgeries. The early post-operative IOP rise is significantly less. The significant improvement in visual acuity along with the IOP control, and this decrease in the number of glaucoma medications. When we are dealing with these angle closure cases for a combined surgery, there are certain pre-operative considerations which we have to take into account. You have to find out whether the significant visual loss is due to cataract or glaucoma. You have to do a thorough examination because most of the patients will have shallow AC, pseudo-exfoliation, iodorensis, phacodorensis, myotic pupil, or synechials. Posterior fundus examination should be done to rule out what is the reason for the visual loss, and you can consider intravenous mannitol or acetazolamide if the pre-operative IOP is very high. Operative considerations, you should be well prepared to deal with the myotic pupils. So you should try to use a cohesive or a dispersive, both the visco, and should know when to use. That is very, very important. Rexis site should be of adequate. You should not do a small rexis because if the patient is having pseudo-exfoliation, you might land up in post-operative capsular phimosis. The iodization should be performed very slow and in a controlled fashion to avoid the iris forcing towards the incisions. IOL selections, you can select any of these PMA or acrylic IOLs which are available now, and if at all there is no capsular support, ACIOL has to be avoided. You can implant an SFIL or an iris lens, but ACIOL has to be avoided. Intraoperative pulse, start your incision just inside the limbus, create a two-step incision. If you are using a cystotome, try to make a capsular excis. Consider putting the needle on your viscoelastic syringe so that whenever the AC is shallow, you inject and the AC is reformed. As I told you, you should know when to use a dispersive and a cohesive viscoelastic, and you should always suture the corneal incision at the end of the combined surgery. Post-operative management, medications, and the potential complications are the same which you have for any other cataract and trabecular surgery and should be tailored out. So coming to the techniques, there are basically two techniques of combined surgery. You have the single site technique or the twin site technique. Single site technique, that means the phaco and the trabeculotomy is done on the same site. Usually it can be an SICS or a phaco plus IOL plus trab. Twin site, you have the superior trab and a temporal phaco, most commonly done for as a phaco trab procedure. When we look at the studies, single site versus two sites, twin site group had 1 to 2 millimeter more IOP reduction and required less post-operative medications, although this difference was not statistically significant. So I'm just showing a small video of how to do a twin site surgery. The superior rectus suture is taken, and I use a subconjugation of mitomycin 0.02 milligram per 0.1 ml. You should always mark your congenital flap. So in the case of a phaco trab, I'm marking at a 3.5. In one go at the limbus, have one small nick and then separate the tissue and then try to go subconjunctivally as much posteriorly as possible so that you have a diffuse bleb. Once it is done, try to identify the bleeders and only cauterize the bleeder. Don't cauterize generally the whole sclera, because if you do that, if you do excessive cautery because of this, there will be scleral flap shrinkage. Again, mark your scleral flap, So when you mark for 3.5, you'll end up in getting a 4 millimeter. I always do a triangular flap, so it depends on your choice whether you want to do a triangular flap or a horizontal flap. So the depth of the incision for the triangular flap should be adequate. Raise the apex with the help of a Hoskins forceps or a blunt forceps or one-tooth forceps, and try to make the separate the flap in one go. You should have a smooth edge of the scleral flap. Once this is done, then shift temporally and now proceed with your phaco incisions. So the, 2 side port incisions are done. Staining of the capsule is very, very important because most of the angle closure cases, we will end up in having a mid-dilated pupil, and the cataract also might be very hard. Rhexis is marked with the help of a Rhexis marker. This gives you a rough guideline that what will be your Rhexis size. Follow the whichever routine procedure of your phacoemulsion which are used to. But what I would recommend is to do a slow motion phacoemulsification. You see, the moment I did the hydrodissection, this is a floppy iris, and the whole pupil is become mid-dilated. So whatever technique of your choice, whether you want to do a stop and chop, direct chop, your whatever phaco choice you are comfortable, go ahead with that. Just make sure there's not much of turbulence into the anterior chamber, because if that is there will be a lot of pigment release, and these are going to occlude the angles which we don't want. So that's why I recommend slow motion phacoemulsification. Once you are done with the phacoemulsion, inject the IOL, and when you are injecting the IOL, you have to make sure that the haptic, the IOL is inside the bag, and orient the haptic at 3 and 9 o'clock position, because you don't want the AC to be the lens to be the sulcus, because sometimes what happens is the haptic is oriented superiorly through the peripheral iridotomy. What you do, the haptic might prolapse out. So as I told earlier also, always suture the main wound after you finish your phacoemulsification. Now the cohesive viscoelastic substance was there. I washed it, because at this step I want to go behind the IOL and wash up whatever visco is there. And now I'm going to refill the visco, but this visco is going to be only into the anterior chamber, so that when I'm going with my trabeculectomy, I shouldn't have a AC collapse. You have entered the anterior chamber with the help of a 2.2 keratome, and with the help of a Kelly sponge, you just make sure that your internal ostium opening is adequate. I do a mushroom shape internal ostium, and this gives me a better control. So once the trabeculectomy meshwork is cut, then you do a small peripheral iridectomy. Because visco is injected, and always make sure that you don't overfill the anterior chamber with visco. You overfill, you will have a lot of iris prolapse in these angle closure cases. So only adequate visco substance should be there. I'm putting a releasable suture. This is of great help. Always try to put at least 2 releasable sutures, one at the apex and one at one of the walls, because these releasable sutures will help you control your bleb, titrate your bleb post-operatively. So the technique of releasable suture is what I follow this. First into the clear cornea, then perpendicular to the limbus, into the scleral flap, and then from the scleral flap into the intersclera. So this is an intermittent suture which I am putting, so 2 releasable, 1 intermittent. Once you have done that, the conjunctival closure is very, very important. Throughout this procedure, whenever your AC is collapsed, make sure that you reform with air or cohesive. I start using air because I want the visco to come out as much as possible, because you keep the visco for a long time, you will have a fibrinous membrane. Conjunctival closure is very, very important. Always make sure that you take an episcleral bite. If you don't do that, the bleb will recess behind, and then you will have difficulties and leak. So make sure that you take the anchoring suture at the episcleral tissue, and interlocking sutures are put into the conjunctiva, and that gives a very good tight closure in the limbus, and do it on either side. And once this is done, you can use subconjunctival decagenta, whatever you are comfortable with, and this is the way the twin site surgery is done. Coming to a single site, just a small, very small video clip. I still have 1 minute, 15 seconds left. So all terms are same. Only the thing is here the wound mark is 6.5 millimeter, because I'm going to do an SICS plus trap. So 6.5 millimeter is the flap size, or the conjunctival flap size. Identify the bleeders, cauterize the bleeder, again 6.5. And in this also I'm doing a triangular incision. There are different variations when you are doing SICS trap. You can do the triangular incision, you can do the straight incision, you can do a rectangular incision. But I'm used to triangular, and triangular gives us a better exposure. So you see the flap has to be uniform. And now the steps are same for SICS. Once you have created the flap, the 2 lateral lawns of the SICS surgery is created. The anterior chamber is entered with the help of a keratome. Side port is created, and all the SICS steps are followed, and then the internal ostium is created with the help of a Kelly sponge, and all these procedures are same. The remaining procedures remain the same, so there is nothing different in that. Only the incision size is different when you are doing an SICS trap, and the site is the same site technique. So this is what I wanted to talk about the combined surgery.
Thank you so much, Dr. Porwal, for your wonderful presentation of a difficult topic, and comprehensively covered through both the videos where you touched upon right from the incision to the conjunctival closure. Thank you so much. And now I'd like to invite Dr. Ankur Sinha for his talk on landmark studies on primary angle closure.
Yeah, Amit, wonderful videos. Just one point, I just noticed that in the phaco parameters, I think we should also stress that the parameter bottle height should be low, and we have to, because I noticed you had kept bottle height of 100, which gives IOP of about 70 millimeter of mercury.
Yeah.
So that becomes hazardous, particularly in moderate to severe glaucoma if we are doing combined surgery.
Okay, so as I told you, whatever is your preferred choice, go ahead with that. Slow motion phaco is preferable, but if you know that your CD count is less, your turbulence is less, you are going to finish your emulsification in a fraction of 20 to 30 seconds, then you don't have to worry about that.
Ankur, I think Dr. Sirisha is here. Can we give her the, you'll be next, just stay there. Dr. Sirisha is going to start with the most basic talk, which was what is the critical step to confirm that you actually have a patient who has angle closure. I think the rest of our talks are completely meaningless unless we are absolutely sure what we are treating. So Dr. Sirisha, if you could start with that. Ankur, yahin baith jao.
Okay. Thank you. So this was supposed to be given by Dr. GC, so let me see how I can justify his talk. Critical steps for confirming angle closure disease. I think this is the most important one. So we should start with understanding how you define angle closure, what is very important with the history, starting from history evaluation, and how do you go ahead and diagnose. So like I said, it's very important to define them appropriately. What do you mean by a primary angle closure suspect, primary angle closure, and primary angle closure glaucoma? So once we are clear with this, I'm not going into the definitions, but once we are clear with this, I think the rest of the things will become very easy for us. When I say primary angle closure disease, that I'm going to refer to, that will include primary angle closure and primary angle closure glaucoma. Primary angle closure suspect is something that you know that you need to follow up, and maybe a small cohort of those patients may require treatment, but otherwise they are not clubbed into the primary angle closure disease. So also it's very important to identify the risk factor. Like I just said, all primary angle closure suspects you don't have to treat. Only 1 in 4 patients with primary angle closure suspect over the next 5 years, when followed up meticulously, may develop primary angle closure, and similar number also from PAC will develop into PACG, which means that 1 in every 4 patients in PAC, if you have done a AIOC-PI, maybe you will prevent an angle closure from developing, so which is very, very important as well. So those that have bilateral primary angle closure and those that have a primary angle closure post-PI but continue to have elevated intraocular pressure, and those where the PI was not done in a primary angle closure, so all of these are primary angle closure. So PAC post-PI but have elevated IOP, and those who did not have a PI are the ones who are going to progress faster. So I think it's extremely critical for us to identify these risk factors, and they need to be treated. Often angle closure glaucoma in India is asymptomatic. Very few acute angle closures we do see. We see a lot of chronic angle closure. We see a lot of acute on chronic angle closure. That means by the time they present to us as an acute angle closure, several of these patients can also have a disc damage, which means that it is not just this episode. Prior similar episodes would have happened in these patients as well. Meticulous anterior segment examination is extremely critical, and I think peripheral anterior chamber examination by a Van Herrick's test is something that can be done even in a center where you don't have any other devices available. So with a slit lamp examination, this cannot be alternative to gonioscopy, but at least this can guide you as to in whom you need to do a gonioscope. So grade 1 and grade 2 Van Herrick's as compared, peripheral anterior chamber test as compared to the corneal thickness are considered narrow angles. They definitely require a gonioscopy. If it is possible, do it in everybody, but otherwise, at least in these 2 grades we need to do. Very subtle and obvious anterior segment signs are something that we see in these patients. So you see some amount of sphincter atrophy, sometimes you see large areas of sphincter atrophy, and sometimes you see with acute angle closure, they can present with low IOP, especially if they've had high pressure, somebody has treated them, or because of high IOP and whatever medications they were given, they can go into a ciliary shutdown, so they can present with normal intraocular pressures also. So I think one needs to be aware of that. Asymmetrical pupil size in these patients when you have no other pathology is, unless proved otherwise, is possibly an angle closure where you have pupillary changes plus possibly the disc is also damaged in that eye. And always remember to rule out secondary causes. associated with these conditions as well. Gonioscopy is most critical, all of us know. So for you to know whether there is angle closure or not, it is very critical. Also to understand whether this is occludable, whether there are synechiae and all of these, I think gonioscopy is very important. But apart from just doing a gonioscopy, which is indentation gonioscopy is something that most of us do, but you can do whichever gonioscope that you are comfortable with if you know what you are doing and how to identify the PACS, PAC and of course PAC, but PACG if you have disc changes. So what is important is to know two things. One is the angle occludable? And if the angle is occludable or open, so you have differentiated that, what other pathology is there in the angle? So for which you require both a darkroom examination as well as with a bright light illumination and an examination. So to identify whether this is occludable or not, a darkroom illumination, a thin slit beam and a narrow slit beam, which is the shorter slit beam that doesn't fall on the pupillary area, so that you don't cause the artificial angle opening by pupillary constriction is very, very important. But once you identify this, also it's very important to brighten the light to make a broader beam to understand what else is happening in the angle. That becomes critical. So I won't go into these details, but what is important is when you have an angle closure, if you use a mirror, if you use a lens, gonio lens, that has a higher mirror, and that the mirror that is closer to the center possibly will help you to give you a better view of the fundus, a better view of the angle structures. So where do you do it? In all those who has glaucoma or those who have a suspicion of glaucoma, they need to be done and also repeated in between whenever they come back, at least once in a year or every time when they have a elevated intraocular pressure. Understand what the normal structures are so that they know what the pathology looks like, and appropriate testing conditions are very important. So just to touch upon, sometimes you see pigmentation on the back of the cornea, which is like pigmentation of the Schwab's line, which may appear as if it is pigmented trabecular meshwork. But even then, if your anterior chamber is shallow, do an indentation and then you realize that you have another pigmental line that is there at the back, which tells you that primarily what you were seeing was not a open angle. Blotchy pigments are isolated, patchy pigmentation of the trabecular meshwork. They are a sign to say that there was a prolonged iridotrabecular contact, and that again is a sign of PAC, and that needs to be treated. Of course, you do see synechiae post-PI, identify whether there is plateauvirus or is there any other pathology, whether there is synechiae or pseudosynechiae, or you have sometimes can also visualize things that are structures that are abnormal under the iris. Role of imaging has very limited role, I would say, but then you realize in angle closure, apart from relative pupillary block, there are other mechanisms that are there like plateauvirus and increased lens vault. So we should be able to understand these underlying anatomical abnormality as well, and imaging definitely has a role in picking up these two. So imaging cannot replace gonioscopy, but it definitely can be used as an adjunct. And always remember, PACG can be a masquerade to glaucoma suspect and the normal tension glaucoma patients as well. So, yeah, so this is the last slide. So I would say that angle closure, while primary is most common, remember that there are young people who are presenting or those who present with unilateral angle closure. So you need to remember that there could be secondary causes that needs to be ruled out as well. That's all. Thank you.
Thank you, Surisha. We've had to move the topics a little up and down. So now we'll have Dr. Ankur now talking to us about the landmark studies in angle closure disease. And Surisha, wait here itself. Then we'll have your next talk as well. So I think so far what we've gathered is that the clinical sort of evaluation is most important to know what we are treating. You look at the anterior chamber depth, you look at the gonioscopy in a slightly dim room if you can, with a very bright, very thin light, about 1 to 2 millimeters in height, so that you're only illuminating the angle. And thereafter, once you've decided whether you can actually see the posterior trabecular meshwork or not, you then increase both the height and the width to see what else there is, whether there's blotchy pigmentation, pus, or anything else. So let's look at the landmark studies in angle closure disease.
Thank you, AIOS, for giving me this opportunity. It's nice to be presenting in presence of your mentors. So I'll be touching upon some studies about the primary angle closure. So I pulled upon and found out a few RCTs, the randomized control trials. So I'll be touching upon the RCTs on LPI versus PACS, the Zhongshan and the Singh analysis. the argon laser peripheral iridoplasty in PAC, and the cataract surgery in PACD. So we'll just touch upon these studies and what recommendations we can imbibe from them. So Zhongshan angle closure prevention trial, the ZAP trial, was a single-center randomized interventional control trial, and this was a population-based study. And they took occludable angles as the patient's kind of inclusion criteria. Since it was a population-based study, there were a large number of people. They were screened, more than 10,000, and approximately 889 patients were included in the trial, where one eye was, laser was done and the other eye was followed up over a period of 72 months. So the primary endpoints here were the pressure of more than 24 millimeters of mercury on 2 occasions, developing at least 1 clock hour of PAS or an acute attack of PAC. So there 75% of patients completed these trials, and they found out that 19 patients in the LPI groups as compared to 36 patients in the control group did reach an endpoint. And the cumulative incidence of conversion of PACS to PAC was 4.19 per 1,000 eye years versus 7.97 per 1,000 eye years in the observation group. Then we move on to the, sorry, I just went on fast. Then we move on to the next trial, the SING analyst trial, the Singapore Asymptomatic Narrow Angles Laser Iodotomy Study. So this was a multi-center randomized control trial. This was a clinic-based. 480 patients were involved. They again took bilateral asymptomatic PACS into the inclusion criteria. And out of 1,000 patients, 480 patients were included into the 2 groups. Again, one eye was lasered and other was observed. So they took half clock hour as the endpoint into the half clock hour of goniosynic as a PAS as the endpoint, along with the pressures of more than 21 millimeters of mercury or development of acute ACG or a PAC. So what lessons do we learn from what this study talked about was at the end of 5 years, 5% of LPI patients developed an endpoint as compared to 9.4% on the control group. And the incidence of reaching the endpoint was 11.65 per 1,000 eye years in the LPI group as compared to 21.48 per 1,000 eye years in the control groups. So what do we learn from these RCTs? So LPI itself was a safe with no long-term adverse effects, both the studies talked about. LPI had a 47% reduction risk of developing PACS to PAC in the ZAP trial, and majority the endpoint was development of the peripheral antisynic. So LPI does have a modest benefit in preventing progression of PACS to PAC, but due to low incidence of conversion, the immediate threat to vision is not there because most of the patients, the endpoint was development of PAS. And the rate of developing angle closure endpoint was less than 1% per year in the ZAP trials. Now the number needed to treat in the PAC, number needed to treat the PACS patients to prevent from PAC in the ZAP trial was approximately 44 over the period of 5 years, and that was 162 to prevent the patient who's having a sight-threatening glaucoma if you want to prevent that. As per so both the analysts and ZAP trial compared the incidence, which was much less than what we found in the Indian studies. So in the Indian studies, we had the higher rate of conversion from PAC to PACS. Probably this was because of the difference in the definition used for PAC as compared to, because we just talked about the development of PAS as compared to the number of clock hours. Also, these trials talked about the more protective role of laser PI in conversion of PACS to PAC in the Indian studies. Now we talk about the role of ALPI in acute PAC. So there were 4 randomized trials which talked about ALPI versus medical management in acute PAC. So both ALPI and the standard treatment group used topical pilocarpine till the iridotomy was performed. The baseline IOP at the baseline IOP, the IOP at the 2 hours, and the final IOP was better in the ALPI group. The IOP percentage reduction was also better in the IOP ALPI group. The duration of attack had no impact on the IOP reduction. There was no significant difference of changes in the PAS formation, the CDR, the change in the endothelial cell count, or the requirement of medications post ALPI or the laser group. So both ALPI and systemic medications were equally effective in controlling the IOP, but ALPI lowered the IOP rapidly. ALPI in acute PACs may have technical challenges with the risk of corneal burns, so LPI should be considered as a first choice after control of IOP in most cases. ALPI may be used in patients where LPI is not able to adequately control, more so in cases of plateau iris controls. Now we move on to the role of cataract surgery after acute PAC. So this is a randomized control trial which talked about early phaco plus IOL compared to LPI after an acute PAC. So there were 62 eyes in the two groups. Half of them went in for phaco and half of them went in for laser PI, and 30 completed the 1.5 years of follow-up. So phaco group had a lot of complications, including post-operative reactions, visually significant PCOs, corneal edemas, posterior capsular ruptures. LPI also had risks of closing LPI and having small iridotomies which needed supplementary laser later on. Another study talked about initial management of acute primary angle closure with phaco compared to LPI. So here again, the patients were divided into two groups. 18 went in for LPI and 18 went in for cataract surgery. The endpoints were the rise in IOP from 20 to 24 millimeters of mercury or 25 millimeters of mercury after 3 weeks of surgery, or loss of light perception. They also talked about qualified and complete success in terms of medication use. So they found out there were higher failure rates in LPI as compared to phaco-IOL groups, and 7 patients in the LPI group underwent a phacotrabeculectomy for non-control of IOP. So the lessons we learned here was the IOP, phaco-IOL was more effective in controlling the IOP, but there was a lot of complications, and the phaco-IOL was a technically challenging job in patients who had an acute IOP in the acute ACG in the recent past. They had problems of cloudy cornea, shallow anterior chamber, poor mydriasis, and zonular weakness. So the beginners may find it difficult to do surgeries in these patients. Then we also had a role of early lens extraction in PACD. Again, this was a multi-center randomized comparative effectiveness control trial across 3 centers in 6 countries. So they talked about phaco in patients who had pressures of more than 30 millimeters of mercury or PACG. They excluded symptomatic cataracts and also advanced glaucomas. Synechiolisis and laser iridoplasty was also allowed whenever it was required. The outcomes in IOP, in terms of IOP was not great, but there were increased risk of complications in the CLE group along with the increased mean cost in the CLE groups. So this is the comparison of IOP in the both groups, which was not significant after a particular time. So what we take on from this study is there was a more modest benefit of IOP reduction in CLE after PAC in early PACGs, but LPI still remains the first line of treatment in view of complications because of the phaco. There are many RCTs which talked about the lens vault and the lens thickness. They are all required to find out the patients who will have more benefit from phaco as compared to LPI. Thank you.
Thank you, Dr. Ankur. That was well summarized. But it's important to realize that these are all population-based studies, and in our clinical situations, especially patients who come from remote areas, we may have to modify our approach depending on the current situation. Especially when it comes to lens extraction, the EAGLE study has been quoted a lot to promote the use of clear lens extraction, but a lot of them actually had mild cataracts, and if you look at the difference in the entire group at the end of 3 years, there wasn't much of a difference, about 1 to 1.5 millimeter mercury at the most. So whether it's clinically significant, we don't know, it was just statistically significant. So I think we'll go on to the next study with Dr. Sirisha will talk about the role of clear lens extraction and MIGS, a combined surgery, I guess.
I think this is a combination of many things.
Yeah.
While she's waiting for her slides, is there anybody who'd like a... Are your slides there, Sirisha?
I just want to add that we usually don't get...
Yeah.
Okay.
Okay. So it will be interesting to see where the clear lens extraction stands and what is the role of MIGS in angle closure. I just showed this slide. In angle closure, I think it's not one single mechanism. We all will agree that there is a complex interplay of anatomic abnormalities, including the pupillary block, the anatomic abnormality of the ciliary body and the iris placement, with the ciliary processes being anteriorly placed on the plateau iris, and excess ICL, the lens vault. So while LPI relieves the pupillary block, we know that the other mechanisms of the underlying anatomic abnormality may continue to be present, and sometimes the angle closure may progress. So this is something that we need to remember, and this is where you possibly come to lens extraction, whether it can help decrease the angle closure. Yes, lens extraction definitely relieves the posterior forces crowding the angle, and thereby can help to open up the angle to a great extent. Before moving to the clear lens, I thought I will just take you through the effect of phacoemulsification on intraocular pressure in glaucoma patients, as was published as an OTA series. So in this, the intraocular pressure after cataract surgery, POAG, PACG and pseudoexfoliation, if you see, there is significant reduction in IOP both in PACG and acute angle closure. And the maximum was in acute angle closure, and none of the patients actually required any anti-glaucoma medications in the follow-up. Does clear lens extraction really help? In 2011, we didn't have evidence, as was written then by Ravi Thomas. And in 2015, Dr. Tanudasa's group had shown that clear lens extraction in eyes with primary angle closure with high intraocular pressure was more than 25 millimeters of mercury for at least 8 weeks post LPI and on medications were enrolled into this study. And at the end of 1 year, they found that 86% of these eyes did not require any anti-glaucoma medication. So you remember, this is a very specified cohort here. An EAGLE study, just now Ankur also spoke about it, just to brief about where we stand. So clear lens extraction, although I would agree with Dr. Shanta, were they really clear lenses, we do not know. But according to them, clear lens extraction versus the standard of care, which was LPI and anti-glaucoma medications in PAC and PACG. Those patients who, all of them were over 50 years of age and had intraocular pressure more than 30 and or PACG with a mean deviation better than 15 decibels, and they were randomized to either LPI or a clear lens extraction. So this is a forest plot that looked at the quality of life as well as the intraocular pressure control, both of which favor the clear lens extraction group. However, you need to remember that there was a huge list of complications that were there with any intervention, and of course, in angle closure eyes, you also have to worry about the posterior high pressure, the corneal endothelial problem, and malignant glaucoma that you may deal with, and how many of these patients will continue to, will go on to develop these intraocular problems even later during the postoperative period is something that we need to remember. So to summarize, lens extraction definitely deepens the anterior chamber, helps to relieve the pupillary block, opens up the angle, and possibly increases the trabecular filtration if the trabecular meshwork is functioning well. So to summarize, you will not do a clear lens extraction unless you have an acute angle closure with high IOP or a post-LPI PAC with either a clear lens or minimal cataract with an elevated intraocular pressure. Definitely lens extraction is helpful, or in those patients with a very high lens vault and occludable angle post-PI. So do MIGS have a role to play? All we know about MIGS, in fact, there's been a lot of talk about MIGS in the past few days. In our meeting as well. So typically MIGS are something that we use, the angle-based procedures are something that we use for open angle glaucoma. But if the angle is closed, or if you don't have an approach to visualizing the angle, if there is not much enough space, how do you even go ahead and do an angle-based procedure? So access becomes difficult in these eyes, but if suppose you are able to open up the angle by doing a cataract extraction, you may want to combine it with an angle-based procedure. However, one has to remember, even if the angle is open in these patients, how well is the trabecular meshwork functioning? How is the Schlemm's canal complex in these patients? And if many times you see that goniosynoculosis is something that is combined with either a cataract extraction alone or one of the mixed procedures, do they really help in reducing the intraocular pressure? So these are something that we need to remember. There are various mixed procedures that are available, whether it is ablating the angle structures or trying to incise them, trying to excise them. There are several procedures that are there that we discuss about. All of these, in my opinion, have some role to play if you're combining it with a cataract surgery, or it is an angle closure eye that was, cataract was operated, is pseudophakic now has uncontrolled pressures, and you have additional indications for you to decide on whether you want to do an angle-based procedure or not. You can combine it, but as a standalone, obviously, it doesn't have much role to play. And if you see the several studies that are published, many of them are retrospective studies, but all of them, except maybe one or two, have included phacoemulsification along with doing one of those mixed procedures. So do we have a conclusion, and where is the present evidence, and what is the lack of evidence rather? So mix in angle closure, at least the present evidence says that it shows promise, can be combined with phacoemulsification. Evidence is majorly retrospective. Long-term outcomes, complications, and success rates with and without medications is something that we have to look forward to. And we definitely need RCTs with and without phacoemulsification to know whether MIGS has a role to play. There are 2 RCTs that are ongoing at the moment. So mix in angle closure, phacotrabeculectomy versus phacogoniotomy in advanced primary angle closure glaucoma in a center in China. And the same center was also registered another surgery, another procedure which is trab versus laser LPI with goniotomy in advanced angle closure. So we have to see, because here they are comparing it with the standard glaucoma surgery with and without phacoemulsification. We need to see what the results are like. Thank you.
Thank you, Sirisha. I think it is important to point out that there are issues with doing a mixed procedure in angle closure glaucoma, which she has mentioned clearly. So we'll go on to Dr. Ramanjit Sihota. She is going to summarize a really complex problem, as you have seen with all the talks so far.
No.
No.
Audio.
Hello?
You are audible, ma'am.
So I think the main thing whenever you're treating anybody is to understand what you're treating, and everybody has an opinion. Everybody has an opinion as to what to do, especially in angle closure disease. Primary angle closure disease isn't a single disease at all. So if we look at it, we know that there's an entire spectrum. So you could call PAC a person who has one synechia. You could call PAC a person who has 180 degrees of synechia. You could call PAC somebody who has a 0.3 cup. You could call somebody who has a 0.7 cup but without a visual field defect PAC as well. So I think first we need better definitions, but with what we have, the classification that is currently propounded by the World Glaucoma Association was initially for surveys, and I would say to you that we need to understand what happens in eyes, and that may not be significant clinically. So if you look at what happens in patients who have just the anatomy, you know, as everybody has talked about, that largely we see pupillary blocks, but in about sort of 8 to 20%, we have plateau irises, we have exaggerated lens vault at about 7 to 24%, and a prominent last roll. But are we treating the anatomy, or are we trying to see which patients are likely to develop ITC or pass in the future or have trabecular dysfunction? So when we looked at the ZAP studies that you've already been told about, at 14 years, what we heard was that it decreased the progression to primary angle closure by 66%. What we didn't hear was that they actually excluded all the patients who were anyway high risk for angle closure. So if you actually put that in, you can say that the iridotomies are definitely very safe, as has been proved by the Singapore study and by the ZAP study, and they significantly reduce the progression. And keep thinking that your patients come to you when they are 40, 45 years old, and they are now going to live to 80 or 90. So even if you can reduce the progression to PAC, it is significant for that particular patient. What about iridotomies? What are we hoping to gain from an iridotomy? One is that it widens the angle, and more importantly, what happens is that the IOP fluctuation, because of mild subacute attacks, is actually reduced as well. And again, I would say it's safe, so please think of treating even anatomy, because we know these progress, and especially if there are people who have PAC or PACG in the other eye, don't forget to do an iridotomy in the fellow eye. People with a family history and a very narrow angle, please think about doing an iridotomy. Patients requiring frequent dilation or staying very far away from accessible health care are also indicators for iridotomy when only the narrow angles, that means a primary angle closure suspect, comes to you. What happens after you have sort of moved on and the patient next comes to you, and you can see either a single synechia or you see blotchy pigment, as Shri Sirisha also pointed out, these sort of isolated pigments that you can see, or you start seeing actual synechia or a completely closed angle. So now we have moved on to where the gonioscopy, if we do it well, is actually telling us what's happening in the trabecular meshwork. The trabecular meshwork over time, the first picture here is of primary angle closure suspects with wide open angles, so the aqueous can flow through. Here we have acute and subacute angles, and here we have a chronic angle closure glaucoma. So when we actually see that we could have done an iridotomy at this point, either as a PSCS or as a PSC, we can actually aim to prevent progression to trabecular damage, because trabecular damage is happening because of repeated iridocorneal contact, and also your patients are getting older, so there is age-related changes in the trabecular meshwork. So why should we treat one single pass? If you see one single pass, should we be thinking of treating, doing an iridotomy? And I say yes, because we know that at least about 30% or more are going to progress over time to develop a primary angle closure glaucoma. And which eyes are most likely? Those with very narrow angles, a lens thickness which is more than normal, and those who already have PAS of more than 2 quadrants. So if you want to treat PAS, please think that the reason you're doing it is to prevent further occlusions, further PAS that is occurring. So we do an iridotomy, 2 or 3 weeks later do a diurnal phasing. Make sure your IOPs are sort of in the range of 14 to 17. Rule out anything else like a plateau iris or a lens. Do a baseline perimetry and imaging and review every 6 months. Phaco is considered to be equivalent to an iridotomy as per the EAGLE study and a lot of the talks you would have heard of. So what are we hoping to do with the phaco in primary angle closure disease? The first one is this beautiful cosmetic appearance of the iris that falls back. But what are we doing to all these kind of things that are there in the trabecular meshwork? It is suggested that some effect of the phaco may be partly the ultrasound, which is actually washing out some of the debris. The IOP has been seen to fall 2 to 8 millimeters, but this is largest in patients with acute angle closure, and all of you have seen acute angle closure comes with pressures of 50, 60, you wait, you do an iridotomy, and patients come back with pressures of 14 and 16. So what the additional benefit of the phaco in acute angle closure may just be the fact that the angle has been reopened. EAGLE study, the authors themselves had said this difference of 1.18 millimeters is small and by itself is unlikely to be clinically significant. So do not use clear lens extraction instead of a laser iridotomy, because the difference, at least for those 3 years, was not significant. But we do know that over time, patients are getting older, there is trabecular damage, the pressure is going to rise. And the raised pressure, as we already know from ocular hypertension and other studies, is what leads to the glaucomatous optic neuropathy. So please, if you see an IOP of 20 or 21 in primary angle closure, please treat them. Acute angle closure, I think we're all aware that over time, 20 to 30%, whether you do a lens extraction, an iridotomy or medication, will develop glaucomatous optic neuropathy. As far as the primary angle closure glaucoma is concerned, I would like to tell you that in these cases, the IOP is much higher. When we start, the progression occurs earlier, it worsens faster than in patients with POAG. So please do a laser iridotomy and lower the IOP to target IOPs. What is the role of iridotomy in PACG? As you can see here, in the first picture, the ITC was 100%, and you can see how high the iridocorneal contact was. After the iridotomy, the height of this contact to the trabecular meshwork has fallen, and many areas of the trabecular meshwork that were actually sort of being obscured by the iris are now able to function. Keep your IOPs to target IOP, early defects 15 to 17 millimeters, moderate 12 to 15, and severe 10 to 12. If you can do this, the PACG progression in 10 years is 1 to 2%. Trabeculectomies by many studies have shown that it is very safe, especially when you use releasable sutures. What is the role of cataract surgery in PACG? Many meta-analyses have shown that they actually have some effect, but not significant, and medications still need to be continued in many patients. Somebody was talking about goniosyneculalysis. That also, there's a meta-analysis which has shown that in PACG, goniosyneculalysis has no significant difference in terms of IOP. But what are the visual changes after cataract surgeries? A lot of people lose vision because it's a complicated surgery in a very narrow anterior chamber depth. We know that PACG can progress even after lens extraction, and people sometimes don't go back for a regular review. lot of people also say that if the AC is very shallow, 2 millimeters, 2.5 millimeters, then a lens extraction is probably going to help. But actually, there is no cutoff that has been actually said that at this point you start needing to do a phaco trab rather than a trab. Releasable sutures has made our lives much, much better. And every meta-analysis says that the addition of a trab to a phaco lowers the IOP much more, reduces all the problems that you're likely to have. Just this last 2 slides, one says that the narrower the angle, raised IOP, the extent of the pass is what actually tells you how your patient is going to progress further. And after that, don't forget that ischemic heart disease, steroid use, IOP fluctuations, just as in POAG, continue to happen in our PACG patients. I think he's taken away my last slide, but that basically was that you can prevent primary angle closure glaucoma and visual field loss if you treat at least all PACs. Even if you see one synechia, do an iridotomy, you have done that patient a favor, and for the rest of her life or his life, this may not progress to a point where they actually go blind, which is what most of our patients that we see present with these days. Thank you.
Thank you, Dr. Ramanjit. That was a very nice summary of management of a very complex disease. Due to the lack of time, since the next symposium has to start, I would like to thank all the speakers.
We have some minutes. So if there's any questions by anybody or comments, no, 12:15.
Oh, I'm so sorry.
12:15.
Okay.
So if anybody has any comments, yeah, Tutu?
Ma'am, Ruby Thomas study, here there is a 86 PACS he studied, and there's a 22% conversion from PACS to PAC. And JAP study, they have, this is so many amount of population study, and only 4% is there. So
Because you didn't read the study properly. What they actually did as exclusion criteria was anybody who was positive on a provocative test was excluded. So that is why the number that actually progressed in the ZAP study was so low. And the Singapore study did exactly the same. So they are not actually studies that are clinically significant. They are just done on large number of patients, that's all.
So ma'am, the next thing is then how to treat a PACS totally, asymptomatic?
How to treat PACS?
Totally asymptomatic.
Yeah. I think PACS, as we said, high risk. What are high risks? Very, very narrow angles, patients with a family history, patients who have actually got need for retinal sort of frequent dilation, patients who come from very far away. That's about all that we can say for PACS. But I think what has helped us from the ZAP study and the Singapore study is that they have cleared the iridotomy from any complications. So they said it's a very, very safe procedure, and it can be used wherever you think it's necessary. We can't have cleared all your doubts. Come on, somebody.
In chronic primary angle closure glaucoma, where the pressure is about 40, and will you still try with a laser iridotomy first and then go for the trabeculectomy?
Yeah, if the pressure is high, you can start the patient on medical treatment to lower the intraocular pressure and then perform the peripheral iridotomy, even in chronic angle closure. It would be possible. It is not necessary to perform the iridotomy immediately before getting the intraocular pressure reduced.
Yeah.
Because in the presence of high intraocular pressure, the complications of an iridotomy would be a little higher.
And when do you decide about this filtration surgery? What is your criteria?
Pardon?
Filtration surgery, trabeculectomy. Trabeculectomy. Like comparing the laser iridotomy and trabeculectomy.
Trabeculectomy?
Yeah.
No, we can always try a laser iridotomy first. There's no need to proceed to a trabeculectomy right away. You start the patient on medications, perform the iridotomy, wait for some time to see if it is effective, and then if it continues to rise over a period of time, and then a trabeculectomy will be required. I think there are studies done in Singapore and in the US where they looked at the progression of chronic angle closure over a period of time, and almost 56% required trabeculectomy over a period of time. So there's no harm in waiting, but follow-up is extremely important.
Thank you.
And in about a third of patients, you can actually get it under medical control and not go on to trabeculectomy.
Thanks.
My question is that sometimes there are patients with cataract and a primary angle closure glaucoma where the pressures are not getting controlled with the maximal medical treatment, including tablet Diamox and baby glycerol. And then in that situation, would you recommend a combined surgery or do a trabeculectomy first? Because the risk of a complication of a cataract surgery is very high in an uncontrolled pressure eye because there can be PCRs and all. So should we control the pressures and then do a cataract later? Or do you recommend a combined surgery in the same sitting?
Yeah, angle closure with cataract, uncontrolled pressures, I would prefer a combined surgery because you know that only trabeculectomy with presence of a cataract, the shallowing of the anterior chamber and worsening of the cataract is going to be there. So it will also help to reduce the intraocular pressure much better compared to only a trabeculectomy. So for a POAG, I think the treatment is slightly different, but PSEG, when you have even an early cataract, your threshold to do a cataract surgery will be low.
Okay, I was just worried from the point of view that, the risk of having a complication during a cataract surgery because the lens somehow it forms a barrier for the anterior fluctuation to transmit posteriorly. So, are there higher risk of having a complication of cataract surgery when doing a combined surgery in very high intraocular pressure?
I think I'm going to throw something else into this mix and say how significant is the visual field loss or the the glaucomatous optic neuropathy. So if it's mild to moderate, I think, we would say uncontrolled, think of a phacotrab. But when it comes to severe, you may be probably looking at doing a trabeculectomy and waiting the 2 or 3 months and telling the patient that you may require a cataract surgery at the end of 3 months. So in that case, the trab has actually lowered the IOP and will take care of any problems that you might have afterwards with the cataract surgery.
But you can do both, depending on what the situation is.
On the optic nerve.
On the optic nerve. Thank you.
I think we have to remember that phacoemulsification has been a boon to the glaucoma surgeon. I come from an era where I have done extracapsular cataract surgery in these situations, and we have had choroidal hemorrhages and all kinds of complications. But now with the present stage, with the kind of skills that cataract surgeons have developed, performing phacoemulsification and trabeculectomy, a situation like that is not difficult. Of course, as Dr. Ramajit said, patient with very advanced glaucoma and significant visual field loss, you would perform a trabeculectomy alone.
All right. I also have moved from an institutional practice to a private practice. I now find it difficult to find a glaucoma patient who is still phakic. But I still have patients who are on 3, 4, 5 medications. So please do not think your lens extraction is going to cure the glaucoma, is going to control the glaucoma.
So in many PACG patients, after TRAB, even after, the AC remains shallow no matter what we try to do. And sometimes we have to go to reform the AC or do an IZHV. So which cases do you think we should do a prophylactic IZHV along with the TRAB?
I'm sorry, we didn't get that question at all. So you've done a TRAB and the AC is shallow?
It remains shallow, no matter. Conservatively you've managed it, then you've gone to reform the AC also, still it remains shallow.
I think her question was, will performing a peripheral iridotomy prevent this kind of complication?
No,
right?
IZHV.
Yeah, so her question is, where is an IZHV indicated or when is it indicated post-trabeculectomy if you see a shallow anterior chamber? So diagnosis of malignant glaucoma is what you are coming to, right? So you do manage it conservatively, and often I would say at least 50% of the patients are able to respond to medical management. So cycloplegics, aquasuppressants, both topical and systemic will help. And in situations where despite if conservative management, if it is not going to relieve, then depending upon what the lens status is and what is the shallowness of the anterior chamber and things like that, you would want to plan either an IZHV alone or pars plana vitrectomy with an IZHV. And if it is a phakic eye, you may also want to remove the lens. So I think there are lots of things that are there, and it's a very difficult question to give a simple answer. But I guess if it is malignant glaucoma, first of all, diagnosis is most critical. But if you ask me prophylactically, would you do it? Like if one eye has had a malignant glaucoma, with everything that you did and still required interventions, when you are operating the contralateral eye of that patient, then possibly you will want to plan something prophylactically.
I hope we've answered your question. All three of us got different sort of idea of what your question was. Any other questions, opinions, comments?
One question for Dr. Sirisha. Ma'am, if in a very small subset of PAC with ocular hypertension, and clinically you see that there is, the lens vault is on the higher side, and there's a diffuse shallowness of the AC. So what would you plan? Would you go for a LPI, or what would be your plan of management?
LPI first. LPI first, and followed by, if required, if it doesn't help, or if the pressures continue to be high, then I think we can think of lens extraction.
So I think in this progression from PAC to PACG, I keep saying there has to be an element of a raised IOP to produce the optic neuropathy. I remember Dr. Sirisha saying, but a lot of our PACG patients don't have high pressures. I think the one thing to remember that differentiates POAG from PACG is the intermittent rises in pressure which are occurring every time the patient goes into a dim room or is in twilight. So these intermittent pressures may not be recorded by you when the patient comes to the hospital or you've done an iridotomy. So please remember that when we say PAC ocular hypertension, we're saying chronically raised IOP. But anything that happens to the trabecular meshwork with the iris coming into contact with the trabecular meshwork intermittently is also raising the IOP beyond possibly the ability of the optic nerve in that particular patient to sustain itself. I think we've reached the end of our time, and I'd like to say that the presentations were all very good, very, very comprehensive, and thank you so much for the audience to have come to listen to almost the last session today. Thank you.